Well, good afternoon, everybody, and a happy holiday season to all of our attendees. And as always, welcome to our monthly employee benefit. I'm Dan Gowan with Assurex Global. I want to thank everybody for joining us here today. Today, our friends and experts from BenefitComply will be providing a end of the year compliance wrap up. As we're getting started, we'd like to ask you, as we have historically done, a couple of polling questions. And today's polling questions are about your medical plan increase for 2025. You should see a couple of questions that are going to pop up here on your screen. First, what we'd like is for you to please let us know what your company's final medical cost increase was. That's after everything, right? That's after you changed your plan, your carrier, your network, whatever the case may be. After you made all those changes, what's your final increase? And then you'll see a secondary question about the primary driver of that increase. So if you just take a moment and let us know, we'd appreciate it. As you're doing that, you're likely aware that employers are experiencing really a third year of health plan increases that have exceeded an average of 5%. And depending on any sort of industry source that you reference, that increase could range between 5 and 9%. So we're kind of curious where the data falls for the group. And as you're submitting your selections here, I just want to cover a couple of items. First, certainly as always, a special thank you to the local insurance benefits advisors and consultants who are partners of Assurex Global for making today's webinar possible. We certainly welcome your questions today. If you have any questions at any time during the presentation, we ask that you please submit them using the Q&A function that you will find at the bottom of your screen. Our sessions are always recorded. A link to that recording, as well as a copy of the presentation slides, will be available to you early next week from the benefit advisor who invited you here this afternoon. And after I'm done with comments, we'll drop a link to the presentation slides in the chat section in just a minute. I'm just going to give it a couple more seconds here on the last poll responses to come in. We did ask about these medical increases last year. We found that 26% of our respondents had an increase between 4 and 7%. Another 24% had an increase greater than 10. So a lot of big increases that came in last year. And looking at the data, we've got a significant amount of people experiencing a percentage increase of at least 4. So that's the case. So I think with that, we'll go ahead and close those. And please be sure to stay for the closing comments. We'll have one more related poll question. But for now, we're going to get into today's content. We're fortunate to be joined by 4 experts from the BenefitComply team. They are Reagan Debon, Principal, David Flotten, Senior Consultant, Delaney George, Consultant, and Amanda Olam, Consultant. Team, and especially Reagan, I will turn it over to you to walk us through today's presentation.
Unmute myself. That'll help us kick things off. But thank you, Dan, for the welcome, and I'm glad that the whole team is here. I want to thank all of you for choosing to join us today, and to the benefits advisors that invited you here today. We're going to go through lots of stuff. This truly is going to be a high-level overview of lots of different things. You can see here, we're going to spend just a little bit of time taking you through some of the more significant compliance changes that were introduced in 2024. We are also going to do a very quick overview of some important upcoming deadlines, specifically around some reporting that needs to be done. We will give you a reminder of the 2025 requirements and limits as you're all kind of preparing to jump into the 2025 plan year to make sure that you've got everything aligned. And then finally, as promised in the intro, we're also going to talk about some things to watch as we go into 2025. There have been some court cases that we've been watching, some decisions in the past that we're still watching play out. And of course, as the new administration comes into office early next year, there is some uncertainty as to how that may impact the different rules and regulations that we're required to follow for employer-sponsored benefits. So that will be in that last section today. But to kick things off, Delaney is going to talk to us a little bit at first about some of the compliance changes that were introduced in 2024.
Thank you, Reagan. Okay, so first up, that was introduced in 2024 is a new notice for hospital and other fixed indemnity plans. It will be coming into effect as those plans renew in 2025. And the notice itself is right here on the screen in that blue box. That is the notice that's now required. And you can kind of tell that, the main purpose of this notice is just to help folks understand that these policies do not offer comprehensive coverage. They are not health insurance, and have a more limited dollar amount that they'll be reimbursing. The notice must appear on the first page of any marketing, application, and enrollment materials that are provided to employees. What exactly constitutes that kind of materials can be a bit of a facts and circumstances question, but definitively though, the preamble let us know that any documents that advertise these benefits or offer an opportunity to enroll or re-enroll in those plans are the materials that need to have this notice on top. And they say that it's the first page of these materials, but when you think about a benefits guide or like an online enrollment platform, it's not necessarily always going to make sense for this notice to be the first thing on top of a benefits guide that very well may have health insurance information inside it. And for those cases, the agencies have recognized that it may be more appropriate to just put this notice right on top of the section or the page, the web page that describes the hospital or other fixed indemnity policy. One of the biggest questions that we got about this new requirement is which plans it applies to, because it is only applicable to hospital or other fixed indemnity plans. It does not apply to accident or critical illness or specific disease policies. This requirement is part of the accepted benefit regulations, and there's several categories of accepted benefits listed in those regulations, and hospital and other fixed indemnity plans have their own category, which this notice requirement only applies to that core category, and other plans like accident or critical illness, while they may be indemnity plans, those are separate categories of accepted benefits that this notice requirement will not apply to. Okay, I think that covers everything for this notice. Yep. Right, and also big news in 2024 was an update to the HIPAA privacy rule, where a new category of a prohibited use or disclosure of PHI was introduced. We're coming up on the compliance date for that part of this update by December 22nd. And what plans really need to do to be prepared for this update is to update their HIPAA policies and procedures that recognize this new category of prohibited disclosure of PHI, and update their HIPAA training as well to recognize it. This rule was definitely triggered by the new state laws that have come out around abortion regulation since the turnover of Roe v. Wade and the Dobbs case. And it's really aimed at, because it does apply to PHI that is potentially related to reproductive health care, and really requires that in certain instances where that kind of PHI is requested, now covered entities will need to first obtain a valid attestation before releasing that PHI. And what that attestation does really is just promising that that PHI will not be used to impose liability for or identify someone for imposing liability for facilitating or providing or receiving reproductive health care. The other update on this 2024 privacy rule was there are more updates to the notice of privacy practices, including, changes related to this new category of prohibited disclosure of PHI, but also related to substance use disorder patient records. But we've got a while until that compliance date in February 2026, by which time we would expect that a new model would have been released that will comply with these new updates. So for that part, we just really need to set a calendar reminder to update the notice packet before that time. Staying kind of in the vein of HIPAA and security, there's been cybersecurity guidance released this year. The original cybersecurity guidance was originally released back in 2021. However, there was some confusion over which plans that guidance really applies to. And so this year, the DOL in October, I believe, clarified that this cybersecurity guidance does apply to all ERISA health and welfare benefit plans, not just retirement plans. And though, to be clear, this is merely guidance. It really describes what best practices are. And so it isn't strictly requirements. However, ERISA fiduciaries will definitely need to take care that they are implementing what would be appropriate security protocols based on this guidance. And just connecting it full circle back to HIPAA, if plans are, establishing and following HIPAA policies and procedures, particularly under the HIPAA security rule, that will go quite a real long way in implementing those appropriate cybersecurity protocols that they'll need based on this guidance. And then one other new thing this year, we got more guidance on what qualifies as preventive coverage for HSA eligibility purposes. Now, generally, to be HSA eligible, an individual has to be enrolled in an HDHP, not have any disqualifying coverage, and not be a tax dependent. In terms of what constitutes disqualifying coverage, there is an exception for preventive coverage. So an individual may receive preventive coverage without jeopardizing their HSA eligibility. And what is considered preventive coverage is what we received more guidance on just this past October. And the new guidance kind of clarifies that breast cancer screenings, including not just mammograms, but MRIs and ultrasounds, glucose monitors, any form of insulin and devices to deliver that insulin are preventive, as well as over-the-counter oral contraceptives, regardless of there's a prescription, and male condoms will all be considered preventive coverage for HSA eligibility purposes. In addition to the other 3 boxes that we already have up there that have come from previous guidance through IRS notices, similar to the one that we got this year. It also, this definition of preventive coverage includes the ACA's definition of preventive coverage. And I want to emphasize that preventive coverage for HSA eligibility purposes is different than ACA preventive coverage, though ACA preventive coverage it's narrower, but is included in the HSA definition of preventive coverage. And so that can be a point of confusion, but it is included in the broader definition for HSA eligibility purposes. All right. I think Reagan will take
That's where it flips to me. So switching to the Mental Health Parity and Addiction Equity Act, the MAPIA final rules that were released just this fall, keeps the basic structure of the mental health parity rules that we were already kind of starting to understand in place. It doesn't necessarily change that. What has happened over time, over the past, more than a decade now, is they keep adding requirements through a mix of legislation and regulations that really increase and try and build on that framework that's in place. We've been getting lots of questions, especially as these final rules came out, about which group health plans are required to follow the mental health parity rules. And it really is very broad. It is both ERISA and non-ERISA group health plans, grandfathered, non-grandfathered, grandmothered, self-funded, fully insured, the whole gamut. They are all subject to these mental health parity rules to the extent that the plan provides coverage for mental health or substance use disorder benefits. The only exception is a small carve out for small employers, very small employers. So employers with less than 50 employees. For a private employer, the plan is not technically subject to these rules. And then non-federal group health plans with less than 100 or more employees are technically not subject to these rules. That being the case, smaller employers also tend to offer fully insured plans, and the carriers are required to offer those fully insured plans in accordance with these rules. So that makes the exception even smaller. It would be these very small employers that are offering either a self-funded or a level-funded plan are really the only ones that aren't required to comply. To the extent that plans are required to comply, we've got the basic parity requirements at the bottom. At a very high level, the idea is that the coverage that is made available for mental health or substance use disorder benefits has to be as good or better than the benefits that are provided for medical surgical benefits, both in kind of how the plan is written and as in operation, how it's actually playing out, for example, from a processing claims perspective. There are some specific notices tied to this. They're primarily just when claims are being denied, that certain information has to be provided for why those claims are being denied. And then the most recent addition to these requirements is this written comparative analysis that focuses in on the non-quantitative treatment limitations. That's going to be things like your prior authorization or step therapy, kind of fail first, medical management techniques that might be in place, things about building out the network and how they reimburse providers and recruit them for their network, those types of things that are in place behind the scenes, really looking at those carefully, analyzing whether they meet the requirements, and then documenting that you've gone through and done that analyzing and proving or coming to, stating those conclusions as to whether those are being provided or applied in parity or not. So then on to the newest kind of final rules. What we got is clarification around all of that. Again, not taking any of it away, but adding on to that, we got more clarity around what exactly has to be in the written comparative analysis. And that's what we've got listed out there on the left. For any NQTLs that apply to mental health or substance use disorder benefits, the analysis should go through and include these 6 different content pieces. The exception is number 5, requiring that relevant data, think about kind of the claims data from the prior year, be collected and analyzed to really show that a plan is in parity or not, because that is a newer requirement, they've delayed that until 2026. So that piece does not have to be included in analyses for 2025, but would have to be included for any analyses for 2026 and later. The other new thing that they added that does go into effect in 2025 is that in addition to this written comparative analysis going through and including these 6 different content pieces, for those plans that are subject to ERISA, one or more fiduciaries of that plan, the plan administrator, often the employer, has to sign off. They have to certify these analyses. What they have to certify is that they went through a prudent process of picking their service provider or vendor that compared the analysis, that once that analysis was done, they went through that and reviewed it in detail, that they understand it and ask questions about, kind of the different findings and conclusions, and that so it's not that they're certifying, yes, we know that our plan is fully compliant. That's not what they're certifying. They're certifying that they went through this analysis process, that they're familiar with the report and the findings, and they understand what they potentially need to do on a go-forward basis to bring their plan more fully into compliance with the parity requirements. I do want to just briefly mention, because there is a lot of focus on this written analysis piece, although that's just kind of a piece of what these rules really require. This is not something that gets submitted annually anywhere. It is something that is required to be completed and in your drawer, in your files, available, updated on a semi-regular basis to keep it current. And then it has to be provided if it was requested upon a state or federal audit, or for ERISA plans, plan participants have the right to ask for these analyses, perhaps in connection if there are questions about the benefits that are being only partially paid for or denied. So that was it for the changes in 2024. I'm going to switch gears here just a little bit and do a quick overview of some of the deadlines that are just around the corner. And the first one that I want to touch on is gag clause attestations. This was brand new last year. We have a rule under the transparency kind of package of rules. This was a piece of it saying that group health plans have to make sure that any contracts they have in place between the group health plan and its service providers don't have any gag clauses that limit the information and how it gets shared. So to further enforce this, we're required annually to attest that the contracts for all of the service providers for the past plan year since the last attestation have been reviewed, or that the service providers have confirmed that they looked at it and that these contracts don't have any prohibited gag clauses in them. The first attestation was required by the end of 2023. And now we're required to do it every year by December 31st. It doesn't have to be done at any particular date during the year or even tied to your plan year necessarily, although that might be easiest to just do this as the plan is renewing each year. But you need to make sure that you do it at some point during the year prior to December 31st. And you're always attesting, they say in 2024, you're attesting to, the 2024 would be your attestation year, but then your attestation period is the date from the date that you last attested up to the date that you're attesting now. So we've got an example here where the employer last attested in December of 2023 and then attested just this past month prior to going out on Thanksgiving holiday. So the attestation period for 2024 for this particular example would be December 15th, 2023 through November 22nd, 2024. For fully insured plans, this will be often handled by the carrier. You may not have to do this at all other than just kind of confirm that the carrier is handling that on your behalf. For level funded or self-funded plans, the TPAs or PBMs, other service providers can certainly do this on behalf of the plan. What we've run into is many of them do not. Instead, what they do is send you an email or a letter saying we've reviewed our contracts, they're in compliance, use this as your proof of that, and then now you have to go ahead and do the attestation yourself. And so you go on to CMS's portal and submit that annually online. The other deadline that is just around the corner, we're maybe not quite ready for it, but certainly a good idea to start thinking about it now, and certainly taking action to get this going early next year is the ACA employer reporting. There are two groups of employers that have to do this reporting. Applicable large employers, if you have 50 or more full-time equivalents, either on your own or as part of a larger controlled group or an affiliated service group, they call it an aggregated ALE group. Then you have to report offer of coverage information for all of your full-time employees. You do that on the 1094C and 1095Cs for each full-time employee. Every applicable large employer has to do this reporting. You can certainly get vendors to assist you in this reporting, but there's a lot of confusion, especially employers offering fully insured plans that think maybe the carrier is doing this reporting for you. They are not. Applicable large employers will have to prepare and submit the C forms themselves. For an employer, whether you're an applicable large employer or a small employer, if you offer level funded or self-funded coverage, you don't have the carrier reporting the coverage information in the background on the B forms, and so that's really your responsibility. You are reporting for any individuals who actually enrolled in your plan during the year. If you're a small employer, you use the B forms, the 1094B and 1095Bs to report that information. If you're an applicable large employer already completing the C forms for the other offer of coverage requirements, then you go down to part 3 of the 1095C and you can include coverage information on that same form. The due dates to provide copies to individuals are March 3rd, 2025 for next year. And then the reporting needs to be submitted electronically. Almost all employers have to submit it electronically. There isn't a mailing option anymore, and you have to do that by the end of March of next year. Because we're on this topic, I do want to let you know, I'm not going to go through this in detail, but the IRS, more than any other areas, maybe mental health parity, but I would say even more so here, we're seeing a very high level of enforcement from the IRS. Think that you're annually submitting your self-reporting, that they have what they need then to reconcile that against marketplace enrollment information, and then assess penalties where due. They are doing two things that we are seeing lots of employers getting letters right now for the 2022 tax year. That's where they're currently at. The first one is a letter saying, we think you're an applicable large employer based on the number of W-2s filed and we don't have your reporting. Where is it? And then having to respond to that and potentially submit the reporting if the employer hasn't already. The second letter that we're seeing is for those that submitted the reporting, but it appears that they didn't offer coverage as required. Maybe they didn't offer to at least 95%, or they did, but the coverage to some employees didn't provide minimum value or more likely wasn't affordable, and they think that a penalty is owed, then they'll send out that letter 226J. So just really important that you understand if you're supposed to do the reporting, and if you are, that you're taking care of that, and then also making sure that you're offering the coverage that's required. Then finally, I do want to talk to this hurricane deadline suspension. I appreciate this probably only impacts a portion of our audience today, but still important for those that are in the Southeast region. If you have employees there, if you have locations there, if you have benefit plans that are housed in these areas, similar to the relief that we saw related to COVID during the public health emergency, our normal deadlines under HIPAA, COBRA, and ERISA are suspended. So for example, if someone has a baby at some point, between now and May 1st is when this suspension goes through. Normally that individual would have 30 days to request enrollment for the child and maybe the employee too. That 30-day deadline wouldn't even start until May 1st. So they really it suspends any deadlines either that are already started or that may otherwise start during this suspension, and it delays that, and then the clock would restart on May 1st. So just giving extra time for individuals who may need it due to a variety of different reasons based on what happened due to these storms that greatly affected the Southeast region. And with that, I'm going to turn it over to you, Amanda, and let you talk about 2025.
Perfect. Thank you. So the first thing that we're going to talk about, we're specifically talking about the requirements and limit changes that we saw for 2025. We are going to start out with talking about health flexible spending arrangements. Perfect. So we wanted to give you just a couple of tips here, just how the actual limit kind of functions before we get into the numbers specifically. So when we're talking about a health FSA, unlike I think, we kind of live in an alphabet soup here in this world, but unlike HSAs, when we talk about the limit, we are really only talking about what an employee has elected to contribute to their FSA. So in other words, employer contributions are not going to apply to that annual limit for health FSAs. One exception to that is if you are offering what we call kind of flex credits, where essentially the employer, you are offering either money that can be put towards the health FSA or taken out as cash or other taxable benefits. In that case, those types of contributions would count towards the limit. So just as a reminder, the carryover from 2024 into 2025, if your FSA plan has a carryover as opposed to a grace period, that limit is $640. The 2025 plan year contribution limit for the FSA itself is $3,300, and then there is a $20 increase for the carryover going from 2024 to 2026. A few more tips when we are thinking about these limits. When you are determining, if someone is going to be contributing more than that annual limit, you're not actually going to consider that carryover amount. So they get to actually elect that full annual limit for the next year, even if they have a carryover. Another thing to keep in mind, if you have someone who is electing the FSA mid-year, you're not going to have to prorate that election. In other words, that doesn't, if they join the plan mid-year, they still get to contribute that maximum amount of $3,300. One thing to note though with that, if you have a short plan year, for example, if you are changing your plan year, to a different anniversary date, you do need to prorate that maximum limit. So essentially it would be 1/12 of that annual limit times the number of actual months in that plan year. And then finally, this limit actually applies on a per employee and per employer basis. So in other words, for example, if you had an employee that elected the full annual limit under your plan and they were employed separately from a different employer, they would still get to contribute that annual maximum at that other employer as well. Moving on to qualified transportation benefits. So this year, the 2025 monthly reimbursement limit is $325. That said, there are kind of two separate parts to what employees are permitted to elect on a pre-tax basis and then get reimbursed for on a pre-tax basis under transportation benefits. There is qualified parking, and then there's also combination of commuter highway vehicles and transit passes. So that actually applies, that $325 applies separately. So in theory, you could have someone that actually could be reimbursed up to $650 if it was broken down $325 for each. We also did want to just leave a note here for you. When we're talking about that, we're really talking about the IRS limits and what, again, this is the tax basis of it. But there are also some areas of the country where state or local law may require employers to actually offer commuter benefits, and in some cases, in addition to what is set forth in Section 132. So for example, there are a lot of different parts of California that require it, DC, Illinois, New Jersey, New York City, Philadelphia, and Seattle. And then we just wanted to give you an update here on affordability. So the percentage in 2025 has actually increased. That doesn't always happen. You'll notice from 2023 to 2024, the percentage that you would use to determine whether or not your plan offering was affordable actually decreased. Going into 2025, we have an increase, so it is 9.02% at this point. This percentage matters for two reasons. Obviously, if you are an applicable large employer, that is the percentage that you use when you are determining whether or not your lowest cost single only option is considered affordable under any of the available safe harbors, so federal poverty line, rate of pay, or Form W-2. The other place that this comes into play is that if you have an individual who goes to the public marketplace to try to get coverage and potentially get a premium tax credit to help them pay for that coverage, this is also the percentage that the IRS is using when determining whether or not the coverage that they've been offered is considered affordable by those standards. And it is slightly different because you as the employer, again, if you can meet one of those affordability safe harbors, your coverage is considered affordable, meaning you're not going to potentially be subject to a subsection B penalty. But when it comes to qualifying for a premium tax credit on the exchange, the IRS is actually looking at the employee's household income, which is not going to be known to you. So it is possible, for example, that you may be offering coverage that is considered affordable, which means you're not going to get penalized, but an individual could still actually qualify for a premium tax credit. For example, if they have an alimony payment or some other payment that reduces their annual household income. And then finally, we wanted to update you here on the high deductible health plan and HSA numbers for 2025. So as a little review, in order to be eligible for HSA contributions, meaning eligible to either make contributions to your own HSA or to receive an employer's contributions, individuals have to be enrolled in a qualifying high deductible health plan. To be considered a qualifying high deductible health plan, that plan needs to meet these limits outlined here. So first of all, it has to comply with a minimum deductible requirement for the year. For 2025, if it's a self-only plan, that minimum deductible has to be $1,650 or more. And then for the family option, which means anything other than just self-only, that minimum deductible has to be at least $3,300. I know it is fairly common to embed an individual deductible within that family plan option. It's important if you are trying to maintain HSA eligibility for employees to ensure that that embedded individual deductible within a family plan is at least $3,300. Otherwise, that high deductible health plan would no longer be considered qualified for purposes of HSA eligibility, and anyone enrolled would not be qualified to make or receive HSA contributions. The other piece of this is making sure that that health plan also satisfies the maximum out-of-pocket limits. You can see the numbers there for self-only and family. And then finally, the 2025 HSA contribution limits. For self-only for 2025, it's $4,300. For family, it's $8,550. And we still have that $1,000 catch-up for anyone age 55 or older by the end of the plan year. Now, that is just the maximum annual limit set by the IRS. A specific individual's own maximum for the year may actually be different. For example, if they are not HSA eligible for the entire year, or they have self-only coverage for a part of the year and family coverage for another part of the year. So the way that you calculate that maximum annual contribution for a specific individual is to take 1/12 of that annual maximum times the months that they are HSA eligible within each of those tiers. There's also a rule It's a little more complicated, but if the individual is HSA eligible December 1st of a given year and remains HSA eligible until December 31st of the next year, that individual will be considered eligible to make the full annual contribution for that prior year. But again, that does require the individual to maintain that HSA eligibility all the way up until the next end of the next year. And I will pass it off to David.
Thanks, Amanda. I just want to acknowledge, I do see that we've got a few questions that have come in. Why don't we get through my section here, and then hopefully we'll have some time. We'll circle back and take some of those questions. But what I'm going to focus on then is I can do a little crystal ball gazing here and talk about things that we are watching, and ultimately, maybe make some predictions as to what kinds of things we can see happening under the new Trump administration as we move forward. But let's start with a couple of ongoing court cases, or really collections of court cases. Starting with this, if you have an incentive-based wellness program, that is some sort of program that provides a reward or a penalty based on certain wellness activities, those are subject to a couple of sets of rules, the most significant being the HIPAA wellness plan rules. And they've kind of been dormant for a while, but for whatever reason, this past fall, we saw a whole spate, like 9 or 10 large class action lawsuits being brought against employers. Specifically, most of these had to do with tobacco incentives, so like a smoker surcharge or a non-smoker premium discount. Those are basically two sides of the same coin, and claiming that the employers had failed to follow those HIPAA rules. And there are several critical rules when you are doing a tobacco incentive like that. You have to give what's called a reasonable alternative standard. Most commonly, that's if the employee completes a smoking cessation program. And if they do, they avoid the penalty, or they get the incentive. You have to give them the incentive for the full year. That was another common focus of some of these lawsuits. And the other thing is that they don't actually have to quit smoking. They just have to complete the cessation class. Kind of the agencies that recognize it's hard to quit smoking. And so you may need more than one opportunity. And so what a lot of these lawsuits focused on kind of one of those three things, that either the employer wasn't offering a smoking cessation program as an alternative, they weren't providing the full reward to employees who completed that cessation program, or they were requiring people actually quit smoking before they granted the reward. And those three things clearly do violate the HIPAA rules, and that's what most of these lawsuits are about. I don't expect we're going to learn anything new legally out of this. These often are going to settle. It's more that, just like I said, for whatever reason, the plaintiff's attorneys, this is suddenly their focus. So if you do have particularly any tobacco incentive, go back, review the program with your broker, make sure it's meeting those HIPAA rules. But again, this applies broadly to kind of any wellness incentive. If you do biometric screening, for example, and give HSA or HRA contributions based on the results of that screening, that has to comply with the HIPAA wellness plan rules. So kind of look at this as a shot across the bow to just go back, double check, dot your I's, cross your T's, whatever cliche you want to use to make sure that you're compliant. All right, next set of lawsuits. There were a couple of very big, again, class action lawsuits against very large employers claiming breach of ERISA fiduciary duties on the health plan. Now, this was a big thing in the retirement side of the world, probably 10, 15 years or so ago, where the plaintiffs started suing 401k plans left and right, claiming that employers had breached their fiduciary duty in one way, shape, or form in the way they managed those 401k plans. This is kind of, then people are looking at this as well. I mean, ERISA applies equally to retirement plans and health and welfare plans, and the fiduciary duties are basically the same. So if you can breach your fiduciary duty on the 401k side by not carefully monitoring your vendors and managing your plan, why can't you have the same argument on the health and welfare side? Now, the argument is a little harder on the health and welfare side because it's not quite the same. With a 401k, you've got a pot of money that's sitting there and it's either managed well or it's not. Even self-funded health plans, it's not as easy to do that. But nevertheless, that is what these lawsuits are about. And a lot of commentators and observers are kind of waiting and seeing, well, what are the courts going to do with this? Or what are the employers going to do with this? Are they going to settle? And is this the start of a floodgate of these lawsuits? Or does the court shut them down pretty quickly and we kind of all breathe a collective sigh of relief? In the meantime, what it means, there were some very unique facts about the employers who got sued in these cases. They were very big employers. They were much more involved in the way their health plans operated than your average, 100, 200, even 1,000 life employer is likely to be involved. So, the facts are going to be very different. But what it is really doing is kind of saying, look, you do have an obligation to make sure that you are running the plans and operating the plans in a way that benefits not you, the employer, but benefits the participants. And so it always makes sense to be thinking when you make a choice, when you make a decision, is this in the best interests of the participants or not? Or am I doing something that benefits me or that is going to give me some financial advantage at the disadvantage of the participants? And, I have had some employers who have, realized they've been doing things that maybe were a little on the edge already, and maybe they need to step back. Just as an example, I had several closely held corporations that were covering family members of the owners left and right, willy-nilly, and lo and behold, those family members were the high-cost claimants. So if you think about it, what you've got there is you're providing coverage to people who are not connected to the business. They're not employees, they're not owners. They're driving up the cost because they're the high-cost claimants, and who's paying for that? If you're passing that on to the employees, that's arguably a breach of fiduciary duty. You're benefiting you and your family at the expense of employees. So, point being, we want to pay attention to this. This could be the next big thing on the horizon, something we need to really focus on, and something we haven't really focused on a lot in the past. So we kind of have to just see where these lawsuits go. Next one is we're waiting to see some legislation. This has to do with telehealth or telemedicine plans and HSAs. And the basic idea here is, if you recall, that in order to contribute to an HSA, you can't be enrolled in a health plan that's not a qualified high deductible health plan. And that means, for example, it can't pay any medical expenses until the minimum HDHP deductible is met. Well, a typical telehealth or telemedicine plan, you pick up the phone and call the provider, and how much does it cost you? Very often, nothing. That's a non-HDHP. It's a health plan. It's providing medical care, but it's providing that care without any cost sharing. And so ordinarily, that would be disqualifying coverage. You can't have a telehealth plan with no cost sharing sitting next to an HDHP and still expect HSA contributions. And it doesn't matter if it's a standalone telehealth or if it's built into the HDHP, there has to be cost sharing in there, okay? Now, during the pandemic, Congress wanted to encourage the use of telemedicine, and so they passed some temporary relief that says, okay, temporarily, you can have telehealth with no cost sharing standing next to the HDHP. That has been extended a couple of times, but the most recent extension is set to expire here at the end of the 2024 plan year, which means unless Congress extends it, starting January 1st, 2025 for a calendar year plan, you're going to have to start charging people what we call an FMV fee, fair market value fee, each time they use telemedicine if you want to preserve their HSA eligibility. Now, there have been a few bills introduced to try and extend this relief or even make it permanent, and those have gone nowhere. But when the last time this was set to expire, what happened is it got put in one of those year-end budget must-pass budget bills and got snuck in that way. I think it was literally 2 days before the relief was set to expire. So there's a reasonable chance that's what's going to happen again this year, is somewhere near the end of this month, some last minute bill will get passed, and tucked in there will be something extending this relief. But we don't know that for sure. And so you at least have to have a backup, a contingent plan that if it doesn't pass, that somehow you're going to start charging those FMV fees on the telemedicine so that you don't interfere with your employees' ability to contribute to HSAs. Okay, so we'll definitely be keeping a close eye on that. This is a longer term thing. and something that lawyers care more about, but it can definitely have some real impacts on all of us. So historically, there was this thing called the Chevron doctrine, and it had to do with administrative law. So, Congress passes a law, there's a perceived gap or interpretation that needs to be made, and the administrative agencies issue regulations. Historically, under Chevron, the courts, if there was a challenge in court related to those regulations, they had to defer to the agency. They had to assume the agency knew what it was talking about and go along with their interpretation. Last year, in a case called Loper, the Supreme Court threw that Chevron doctrine out and said the courts no longer have to defer to the agency's interpretation. They can interpret themselves. They can still take into account the agency's expertise in that particular field, but what it does is it makes it much easier for a court to say that regulation is inconsistent with the law and throw it out. And even just since July, as you might imagine, and there's been a slew of cases, not just in benefits, but in general, that have challenged various agency regs, and they are citing Loper, saying you don't have to defer to that, and we think it's wrong. Benefits is not immune to that. There are, lots of interpretations by the IRS, by the Department of Labor, by HHS, that are kind of reading between the lines. And I don't mean that in a bad way. I mean, legitimately trying to fill some gaps. And there's now just a much greater chance that any or all of those regulations could be subject to challenge. And there's nothing that says just because it's a regulation that's been in existence for 20 or 30 years, doesn't mean it can't be challenged now. So we'll just have to see what kind of lawsuits people bring and what impact the Loper case really has. All right, last slide for me. Again, this is just us trying to take a guess at what might the Trump administration be interested in, focused on in the benefits world. Obviously, a lot of this, we don't have an inside track to anybody in the incoming administration. A lot of this is based on what happened the last time around. That is, we went through this back in 2016 when Trump took over from the Obama administration, and Biden did a lot of the same things that the Obama administration did. So some of this is kind of an educated guess based on what has happened before. So, I mean, I think some fairly obvious things. The Biden administration has interpreted various laws, including in the benefits world, what we know as Section 1557 of the ACA, to interpret prohibitions on sex discrimination to include discrimination based on sexual orientation and gender identity. The Trump administration last time rejected and reissued several regs changing that. I suspect that's going to happen again. I think abortion is another area where I can see them undoing several things the Biden administration did, including, for example, what Delaney talked about the new HIPAA privacy rules around reproductive rights. As Delaney mentioned, that was very much driven by the Dobbs decision and the reinstatement of a lot of state abortion restrictions. Again, I can see that and those types of rules being targeted by the Trump administration and doing those to take away some of those protections. Preventive care. Does the Trump administration feel that male condoms should be preventive care that's paid 100% under a plan? Maybe not. They might try to reverse some of that stuff. The next two, I don't see them reversing. Actually, like cybersecurity, I think is going to continue to be a focus and is going to continue to be a priority for any administration. So I suspect we may see actually an expansion in that area. Mental health parity. I mean, I don't think anybody thinks that they're going to try to undo mental health parity. I think that's a bipartisan. Everybody agrees that's a good thing. But there's certainly been some criticism on the right that the mental health parity rules, particularly things like the NQTL analysis, have become so administratively burdensome that we're losing the forest for the trees. So we could see a scaling back of some of those more detailed rules that we've seen in the last few years. One thing that I think was definitely going to change during the pandemic, the availability of premium tax credits through the exchange was greatly expanded. Those are set to expire here soon, which means that there's going to be a decent number of people who were getting premium tax credits before who won't going forward unless they're extended. I think most people assume they are not going to be extended, which means that individual coverage is going to get more expensive. Now, to a certain extent, that's a good thing if you're an ALE, because it means your coverage being affordable becomes more likely. But it might also mean you have people who were getting individual subsidized coverage who suddenly come back onto your plan. So we'll have to see what impact that has. The Trump administration was back in their first term, where they actually were the ones who first issued rules authorizing ICRAs. Those are still not, widespread, but they are becoming increasingly popular. We get more and more questions on them every day. That could be something I see them pushing a little harder, maybe issuing some rules that make them even easier to use. So that's something to watch out for there as well. The transparency rules and reporting, again, I can see them scaling that back on the notion of its overburdensome regulation. So we may get some relief there, maybe along the same lines on the reporting. We've even heard some rumors there may be some, even under the Biden administration, there may be some scaling on the back of that reporting, but we could see more of that. And then a couple of things that were pushed in the first Trump administration was expanding the availability of these so-called short-term limited duration insurance policies, as well as association health plans. The STLDIs were scaled back again by Biden. I can see that flip-flopping back yet again under Trump. And the association health plans is interesting. The Trump administration did try to expand the availability of those, but they kind of got blocked in the courts. So we'll see if they make that a priority and try and make it easier for unrelated employers to band together and offer group health plans, which is what an association plan is. All right. Let's see. I know we do have another poll we want to do. Are there, and just Reagan, any questions that we think we should tackle here?
I'm going to lump them into two groups and just address them just briefly. There were quite a few questions around HSA eligibility, primarily focused on what would be disqualifying coverage. It isn't dental or vision coverage. It's not preventive coverage, as Delaney described, but any other medical coverage, whether it's, like David talked about telehealth, unless we get that safe harbor, if they've got coverage, dual coverage under another plan, if they've got general purpose HRA or health FSA coverage, if they've got Medicare, when they've got access to other medical coverage, that is what's going to cause individuals to be not eligible to contribute to an HSA. But those are great questions. If you have specific questions about kind of how you're offering things as an employer and how your things fit together, that is a perfect question to take back to your benefit advisor and just make sure that you understand that you're offering and how it works and that you can communicate that to employees. And then the other question we got was just kind of a broad question about calculating affordability for employees. That is not probably something that we can help you with just real briefly here today, because there is some complexity to that depending on kind of what your contribution structure is and which safe harbor you decide is the best fit. But again, that would be a perfect question to take back to the benefits advisors that are helping you set up your employee contributions to not only make sure they make sense kind of with the insurance carrier and for your employees, but also that you're meeting those affordability requirements under the ACA. But with that, I think we can turn it back over for our final poll today, and I'll thank you for letting our team share with you.
Thank you, Reagan, David, Amanda, Delaney, as always, great recap and summary of just a lot of stuff that happened in 24 and may happen in 2025. Before we conclude, we'd like to ask you one additional polling question. You may remember, and that'll pop up on your screen here in a second. I think, hang on. Oh, I was supposed to. Let's see. There we go. We asked you at the top of the hour about your medical plan increase, and now we'd like to see if we can learn about any changes you may have made to your plan for 2025. So please select any and all that apply. if all of them happen, that's fine. As responses are being submitted, just a quick reminder, we did record today's session. A link to that recording will be available early next week from the benefit firm that invited you here today. If you've got additional questions about today's content or today's polling questions, please also reach out to your Assurex Global Benefits Advisor, and they'll certainly be able to assist. I'll give this poll just another moment while we wait for those responses to come in. Just kind of remind everybody, last year what we saw was that the top change implemented was increasing the employee contributions, with over a third of the respondents that picked that option, and then another 22% indicated they were changing their plan design. And just a reminder, we do publish these results from the polls in a document that we call a market check survey. That'll be published sometime next week as well. If you'd like to explore these results further, your benefit advisor can certainly help you with that report. So I'll give it just another second or two here, give everybody else another chance if they want to respond. And it looks like increasing contributions is kind of our winner again, though a number of you did say that there's another change that you made, or that you made no changes. Over a third of you said you weren't making any changes. So I'm sure your workforce was greatly appreciative of that. So we're going to close the poll. I'm going to share the results. And with that, that concludes our time together. As always, we thank our Assurex Global partners for sponsoring today's event. And we thank you, our audience, for joining us. As always, we hope you have a wonderful afternoon, a great holiday season, and end of the year. We look forward to talking to you in 2025. Thanks.